Good afternoon, everyone. I'm Dr. Aravinda Lochani, Consultant Neonatologist at KIMS Cuddles, Kondapur. In today's session, we will discuss about one of the important aspects for improving the overall health outcomes in both preterm and term units, that is the delayed cord clamping. So in today's session, we will see this topic under the following subheadings, that is, what is definition of delayed cord clamping, what is the physiology underlying DCC, and what is fetal circulation and how the fetus transitions to the normal neonatal circulation, and what are the different types of placental circulation that have been studied, and the evidences for different types of placental circulation, that is delayed cord clamping, intact cord milking, cut cord milking, etc. And the advantages of delayed cord clamping in both preterm and term babies, and the caveats or considerations in some special situations. So, if we review the different articles about delayed cord clamping, either through PubMed or other scholarly articles, we find a lot of innumerable articles surrounding the same. In last few years, there have been considerable research on this important aspect of neonatal care. So, if we see um, what is the timing of delayed cord clamping in newborns? So the World Health Organization recommends at least a delay of 60 seconds after birth, followed by clamping and cutting the cord of the baby. The International Liaison Committee on Resuscitation, that is the ILCOR, also recommends 60 seconds for the clamping of the cord. The American Committee of Obstetrical and Gynecology, they recommend 30 to 60 seconds of delayed cord clamping. And our NRP textbook also recommends 30 to 60 seconds of the DCC. So these are the recommendations by the well-known bodies of neonatal care. But the studies, if we see, they have observed the babies with delayed cord clamping for more than 60 seconds, that is 2 to 3 minutes, sometimes in 5 minutes also, and then compared the same with immediate cord clamping. So based on these recommendations, we can all understand that how important is delayed cord clamping for improving the survival of the newborns. So here I am quoting few studies to understand the importance and the benefits of delayed cord clamping. The first one is the delayed cord clamping in very preterm units. This is also known as the APTS trial done by Robledo et al. And published in the JAMA Pediatrics 2022. In this, the population is 1531 babies of gestation less than 30 weeks have been studied. The intervention group is 60 seconds of delayed cord clamping and the control group being less than 10 seconds of cord clamping. In this, they have studied the risk of death or major disability at 2 years of age. So in this study, they have found out that the incidence of death or major disability like cerebral palsy, visual impairment, hearing impairment, motor deficits, cognitive deficits, all reduced by around 17% in babies who have been allowed to have DCC when compared to babies who have immediate cord clamping. So here the relative risk is 0.83 with 95% confidence interval being 0.72 to 0.95. So next, let us see two reviews by the highest body of the neonatal reviews, that is the Cochrane reviews on preterm and term babies. So the first one is the effect of timing of clamping of umbilical cord in premature babies by Professor Heikki Rabe et al. Published in Cochrane 2019. In this, they have taken systematic review of 48 different studies, and they have considered 5,721 babies with a gestation, varied gestation of from extreme preterm of 24 weeks to late preterm of 36 plus 6 weeks. The intervention group mostly, as I have mentioned, the duration was also widely variable between 30 seconds to 180 seconds. But most of the studies they have done between 30 to 60 seconds of DCC. And it was compared with early cord clamping group of less than 30 seconds. In this, different subgroup comparisons were also done. like the effect of DCC followed by resuscitation, routine resuscitation versus immediate cord clamping. The second group was DCC with the intact cord resuscitation with immediate cord clamping. The third one being delayed cord clamping versus umbilical cord milking. The fourth one is umbilical cord milking versus immediate cord clamping. These four subgroups have been studied, and among the first group, the major effect that was seen was the mortality before discharge has reduced significantly with around 27% with a relative risk of 0.73 and 95% confidence interval being 0.54 to 0.98. And there was no decrease in the grades of severe IVH as such, but all grades of IVH, if combined effect was seen, that was showing a benefit in this study of up to around 17% with significant confidence interval, that is the overall value of the range is less than 1. So this was the study, and the next one is the coming to the effect of the DCC in the term infants on both mother and baby dyad outcomes. In this, 15 randomized control trials were taken, and the total number of mother baby dyads which were under study was 3,911. In this, the intervention group had a DCC of more than 60 seconds, and the control group were subjected to the early cord clamping. In this, the outcomes, both maternal and baby outcomes were studied. When the maternal outcomes were seen, there was no increase in the level of maternal postpartum hemorrhage. Severe postpartum hemorrhage in a woman is considered when there is a blood loss of more than 500 ml, and the hemoglobin levels mother's hemoglobin levels were also not dropping. They were not affected by the DCC which was done for the baby. Coming to the neonatal effects, there is improvement in the neonatal mortality rate, and there was a higher birth weight among babies who were subjected to the delayed cord clamping, and they had higher early hemoglobin concentration and increased iron reserves for up to the age of 6 to 8 months. So from these three studies, we can get a basic understanding that delayed cord clamping helps in improving the mortality and other parameters like IVH in preterm babies and iron stores, hemoglobin levels, and overall neurodevelopment in the term and preterm babies. So let us move on. There were subsequent, due to this large number of studies, there were subsequent meta-analysis and network meta-analysis also. The one which is published in January 2018 in the American Journal of Obstetrics and Gynecology. This is a systematic review and meta-analysis in which the delayed versus early umbilical cord clamping for preterm infants was compared. So in this, there were 18 trials were studied, and the overall risk-benefit ratio was observed. So if we treat number needed to treat 33 babies, the decrease in the mortality in the preterm babies was with relative risk of 0.68, that is around 32%, with confidence interval coming to less than 1. Here we can see this diamond towards the left of the midline. That means it favors the delayed cord clamping. So this is a meta-analysis done to study the effect of DCC in preterm babies. So now let us move on to the physiology of delayed cord clamping. So delayed cord clamping, the circulation from the uterus to the baby is dependent on multiple factors. So first is the uterine contractions. So if a baby is delivered by normal vaginal delivery, so the uterine contractions can reach up to 50 to 100 millimeters of mercury with each contraction of the uterus. So the time when the baby is born, actually, that uterine contraction transfers around 2/3 of the blood from the placenta towards the baby. So the remaining blood will be transferred if we allow the delayed cord clamping. So as you all know, the placenta acts as the dual site of gas exchange while the baby is within the womb. And after birth, what happens, due to the stress and the cold environment, baby will cry, and which leads to the aeration of the lungs. Aeration of the lungs and oxygen fills the alveoli and followed by the pulmonary vasodilatation. So the pulmonary circulation in utero, it constitutes to about only 8% of the total circulation of a baby, while after birth it immediately increases to 40 to 45%. That means the blood circulation towards the pulmonary capillaries increases. So thereby, if we allow the delayed cord clamping, the blood which is flowing from the residual placental residual blood volume, so it is around 30% as soon as the baby is born. If DCC is allowed, the rest of the blood also starts flowing through the umbilical vein towards the baby, and via the ductus venosus it enters the inferior vena cava and the right atrium, and increases the pulmonary circulation. So the same amount of blood will be coming as a preload to the left atrium, thereby increasing the overall systemic circulation of the baby, as evidenced by the increase in the cardiac output. So in some studies, after the birth of the baby, the effect of the delayed cord clamping is also studied by 2D echo parameters like observing the fractional shortening of the baby and comparing the SVC flow and left ventricular output have also been studied to know the increase in the volume. So this results in better circulating blood volume of the baby in the first 1 to 2 days of life, thereby increasing the circulatory stability and decreasing the need for inotropes. So as we can all see here, so as the blood circulation towards the pulmonary side also increase, and effectively matches the ventilation perfusion quotient. So there was also an observed decreased need for resuscitation in babies who had delayed cord clamping. In preterm babies, due to this effective circulating blood volume and lesser fluctuations, there was also an evidence of decrease in the incidence of IVH. In term babies as well as preterm babies, this increased transfusion of the blood towards the baby helps in the transfer of the fetal hemoglobin. Thus, fetal hemoglobin improves the oxygenation of the baby, and it also supports the function of the oligodendrocytes in the brain, thereby increasing the myelin content in the developing brain. And in term babies, there has been evidence to observe the um, increased fine motor development and social behavior at around 4 years of age. So this increase in the fetal hemoglobin increases the iron stores in the baby, as evidenced by the measurement of the serum ferritin levels at the infant stage, and also decreases the need for the blood transfusions. There are certain concerns about the increase in the risk of polycythemia and jaundice, but there has not been any substantial evidence to support the same. So as of now, they are not that much proven to deny delayed cord clamping for any baby. So these effects have been studied for up to if the DCC has been done for around 3 minutes after birth. So this slide I have taken from Dr. Satyan's article. So next we will move on. We will continue with the physiology of the this placental circulation. So the normally the intrauterine blood volume, that is the cumulative volume of the blood in the baby, cord and the placenta, is around 110 to 115 ml per kg of the fetal weight. So the umbilical flow is considered as the part of the fetal to neonatal transition, and it should be allowed for up to 2 to 5 minutes or at least for 60 seconds as recommended by the World Health Organization. So by doing so, what we are allowing is, we are allowing around 80 to 100 ml of the blood that is flowing towards the baby, which accounts to about 1/3 of the circulating blood volume in the term babies. So what happens is, this intrauterine blood volume, when the baby is very preterm, only half of the blood will be circulating inside the baby, and the rest half of the intrauterine blood volume will be either in the cord or in the placenta. As the baby's gestation increases, the volume of blood that is inside the body of the baby in utero increases. That's why in term babies, the 1/3 of the circulating blood volume will be still left in the placenta and the cord after the baby is born, while 2/3 of the blood volume will be inside the baby's circulation. So that is the importance of the delayed cord clamping. So preterm babies have higher blood volume, which is sequestered in the placenta, as we have just now discussed. So here in these two slides, we can observe that the percentage of increase in the blood volume and red cell volume, which is caused by delayed cord clamping. Here, this blue bars indicate the immediate cord clamping, where the cord has been clamped as soon as the baby is born, and it has been baby has been transferred to for neonatal care. The second light blue bar indicates that DCC had been done for 1 minute, and the third line, the maroon color line, indicates that the DCC had been done for 3 minutes. Here it is clearly evident that if delayed cord clamping is done for 1 minute, it is definitively better than the immediate cord clamping, as noticed by the increase in the blood volume and the red cell volume, which is shown by the higher length of this bar graph, and it is still even more beneficial if it is allowed for around 3 minutes. So this is from the article by Lind et al. From as way back as 1969. Then itself they have observed the benefit of the delayed cord clamping. So was there any difference in the flow of the blood volume from the placenta to the baby if there is a difference in the height of the baby when compared to the mother's abdomen? So was there any difference related to the gravity? This is this study. In this graph, you can see if the baby is held below the uterus level, that is with the effect of gravity, and at the uterus level and on the mother's chest or belly. It was observed in this study by Professor Ola Anderson et al. In Clinics of Perinatology 2021. But up to 1 minute, if it is allowed, it is still inferior to the um, volume, which due to the effect of gravity, if the mother's baby is kept on the mother's chest or abdomen, which equals slowly by 3 to 5 minutes. Beyond that range, there is no benefit for the baby as well as the mother, because the placenta will start shrinking by then. So what is this placental residual blood volume, and how do we transfer it to the baby? So let us see in this slide. So here they have compared different methods of the cord care. So the first bar graph is the immediate cord clamping, and the second bar graph is the delayed cord clamping by 2 minutes. The third one is the delayed cord clamping here by 5 minutes, and the fourth one is the cord milking. So if you observe here, so if we do the immediate cord clamping, the placental residual volume, like we have discussed, 1/3 of the blood volume of the baby is still in the placenta by the time the baby is born. So that is retained. So that is retained inside the placenta itself if immediate cord clamping is done. If DCC is done for 2 minutes, this value decreases significantly. That is around 10%, 35 to 25. And if it is done for even more, for 5 minutes, it reduces even further. Only 10% is left inside the placenta. Here we can also observe that cord milking is also beneficial when compared to the immediate cord clamping. So in transferring the blood from the placenta towards the baby. So cord milking is in fact, in few studies, it is more beneficial than delayed cord clamping, because it also transfers the mesenchymal stromal cells due to the frictional action of the pull by our hand. So this we have discussed as 30% of the blood volume is still residual in the placenta at the time of birth in a term baby. So DCC for 60 seconds reduces this volume to around 20% from 30%. So till now we have discussed the physiology of the delayed cord clamping, what happens soon after birth, and how this placental residual blood volume gets transferred to the baby. So now we should also realize just what does this cord blood actually contain. It contains 15 to 20 ml per kg of RBC, which is equivalent to one transfusion which we give for a neonate. And it also contains many million to a billion stem cells, which is equivalent to one autologous transplant. And it also contains 10 to 15 ml per kg of plasma. And the amount of iron which is transferred to the baby is enough for a 3 to 8 months of iron supply for a term infant. In addition to this, the cord blood is also rich in a number of antioxidants which help in decreasing the inflammatory changes in the baby, and the increasing fetal hemoglobin, because the oxygen affinity for the fetal hemoglobin is higher when compared to the adult hemoglobin. It enhances the arterial oxygen content and also increases the oxygen delivery to the tissues. So here we can see how important is this cord blood to the baby. So now let us summarize the benefits of delayed cord clamping in preterm and term babies. In preterm babies, the DCC shows benefit by increasing the circulatory hemoglobin F and increasing the oxygen delivery, and it decreases the need for blood transfusion in a preterm baby due to stabilizing the systemic blood flow and the circulation and increasing the cardiac output. It stabilizes the blood pressure and reduces the need for inotropic support, and also increases the superior vena cava flow and increase left ventricular output if we can calculate that. And it also improves the cerebral oxygenation and decreases the incidence of the IVH, less risk for NEC. And in fewer studies, it has also shown a small effect on the decrease in the incidence of the BPD as well. So coming to the benefits of DCC in term babies, it increases the blood volume of the baby by 25 to 35 ml per kg. And it increases the hemoglobin level or hematocrit as documented by the measurement of PCV at around 12 hours after birth, and increases the iron stores for up to 8 months of life as evidenced by the measurement of serum ferritin levels. And it also prevents the anemia of infancy, and because of increase in the myelin content and improving the function of the oligodendrocytes, it helps in optimal neurodevelopment, and it also improves the visual and sensory processing or function of the brain. And long-term effects of DCC are also seen and studied up to 4 years of age, whereby it improves the fine motor development and social behavior of the children at around 4 years of age. So such were the innumerable benefits of DCC. Now let us have a brief overview of the fetal circulation. Let us understand how the fetus circulates while within the womb of the mother. So here you can see the fetal heart. In any fetus, there are three shunts: the shunt across the PFO, and the shunt across this ductus venosus, and the shunt across the PDA. So all these three we are aware of. So this is the four-chamber view of the heart. Here is the right atrium, right ventricle, and left ventricle. So this is the placenta. As you all know, there are two arteries and one vein. The umbilical vein transfers the blood from the placental end of the fetal end of the placenta through the umbilical vein. It enters the baby, and once it enters near the liver, the ductus venosus originates over here. The ductus venosus connects the umbilical vein to the inferior vena cava. So the oxygenated blood which comes from the fetal end of the placenta enters through the umbilical vein, and it enters towards through the IVC and enters into the right atrium. Here through the eustachian valve, so the blood from the right atrium is preferably channeled through the patent foramen ovale to the left atrium, and from the left atrium to left ventricle, and towards the ascending aorta, where better oxygenated blood is preferentially circulated to the brain. So that happens, and then after the first three branches of the arch of the aorta, so then here the PDA will be there, the patent ductus arteriosus will be there. So the blood, the venous return coming from the body through the SVC and also from the IVC enters the right atrium and goes to the right ventricle. And from there, it enters through the pulmonary artery and goes to the lungs. So only 8% of the overall circulation of the baby enters into the lungs, and the remaining is again diverted through the PDA and gets mixed with the residual blood that is coming from the descending aorta, and it supplies to the rest of the body. So preferentially better oxygenated blood is supplied to the brain, and the remaining blood which is mixed after coming from the PDA is circulated to the rest of the body, and that's how the fetus survives in utero. And what happens as soon as the baby is born? So as soon as the baby is born, the after delayed cord clamping, the cord will be clamped and cut. So then what happens? So then the pressure, there will be increased circulation towards the lungs. So the pulmonary circulation will increase. The same will enter to the left atrium as the increased preload, and the left ventricular preload also increases, and so that increases the left ventricular output. So thereby increasing the systemic circulation as compared to the pulmonary circulation. So the increase in the systemic circulation closes the PFO, patent foramen ovale, by increasing the pressure in the left atrium compared to the right atrium. And the PDA also undergoes a functional closure, as you know, within the first 1 to 2 days of life. So this is about the fetal circulation and how the fetus transitions to the neonatal circulation. So now, if we don't allow the delayed cord clamping at this stage, what happens is, as you can easily understand, so the preload to the left atrium will be substantially lesser, thereby leading to the circulatory impairments in a baby. So let us understand the fetal to neonatal transition. So that's why the continued flow in the umbilical vein supports this transition by increasing the systemic vascular resistance and the blood pressure. And in the olden days, they used to see the cord pulsations and believe that whenever the cord pulsations used to stop, the umbilical venous flow also stops. But now there is an understanding that the umbilical venous flow is not related to the cord pulsations. So this fetal to neonatal transition happens faster in a term baby, but it may take longer in a preterm baby because of the different factors like decreased contractility of the heart and slower preferential flow and the longer placental residual blood volume. So any fluctuations in the cerebral blood flow at this stage leads to IVH in a preterm baby. So now let us have a brief overview of the obstetrical perspective. What happens exactly in the third stage of labor? So the third stage of labor is defined as that stage after the delivery of the baby to the delivery of the placenta. So the concern of the obstetrician here at this stage would be the blood loss after the separation of the placenta. If it is more than 500 ml, that leads to the postpartum hemorrhage. So the traditional management of the third stage of labor is administration of a uterotonic drug, immediate cord clamping, and controlled cord traction. But there has been a lot of studies and review of literature going on in the last few years, which show that the delayed cord clamping does not increase in the postpartum hemorrhage of the mother. And we have seen in the first few slides also that the Cochrane reviews and also it doesn't increase the PPH, and it doesn't decrease the hemoglobin levels of the mother. And there is also one more point of view that if we administer an uterotonic drug, it also leads to the over transfusion, that is more than what is required towards the baby. So that is also not proven nowadays. That effect is also not seen because of the newer uterotonic drug, that is the syntocinon. And controlled cord traction had no significant benefit on either the PPH or the baby's aspect. So these were the studies which studied the maternal and fetal outcomes due to the changes in the management in the third stage of labor. So What are the different placental transfusion strategies? The most commonly done is the delayed cord clamping. The other strategies which have been studied and researched are the intact umbilical cord milking and cut umbilical cord milking. So, what are the factors which affect the placental transfusion? So, as I have already discussed, the time of cord clamping, this we have seen as the more there is a delay, like if it is minutes is better than 1 minute, up to 5 minutes, it's beneficial. After that, due to the contraction of the placenta, the blood starts flowing retrograde manner into the placenta again. So it is not beneficial more than 5 minutes. So the time of cord clamping and the uterine contractions, this we will come to see in the next slide. How does it affect in lower segment cesarean section and the umbilical blood flow? So uh, what happens is like the umbilical artery undergoes vasospasm as soon as 45 seconds after the birth because of the increase in the oxygen content in the lungs. The pulmonary blood circulation increases, and the increased oxygen content in the systemic circulation causes the umbilical arterial spasm, whereas the umbilical venous flow continues to flow towards the baby. And with the onset of the respiration and decrease in the intrathoracic pressure, there is a increase in the pulmonary circulating blood volume pool, thereby decreasing the preload towards the heart, and it also helps in the delayed cord clamping. And the effect of gravity we have seen prior in one study. We will see in again another study in the subsequent slide. So the uterine contraction which pushes out the baby, that is the most powerful contraction which pushes around 1/3 of the placental residual blood volume through the umbilical vein towards the baby. And there will be a spasm of the umbilical arteries around 45 seconds after birth, secondary to increased oxygenation in the baby's lungs and circulation. And the pulmonary blood flow, which was in utero around 8%, should increase up to 45% soon after the delivery of the baby to support this transition from the fetus to the neonatal. So because of the delayed cord clamping and continuous umbilical venous flow, the right atrial inflow increases and the cerebral blood flow and oxygenation is maintained. So what happens in LSCS? So all this we have studied till now in the vaginal births, where the uterus will be undergoing contractions and at periodic intervals. In LSCS, the mother is administered with anesthesia. The uterus may be in atony, and there may not be that significant amount of the transfusion of the blood towards the baby as soon as the baby is born, thereby emphasizing all the more the need for delayed cord clamping at least 60 seconds in babies who undergo birth after lower segment cesarean section, because the uterus will be also in atony, so we should allow the blood to flow from the placenta towards the baby. What happens if there is a cord around the neck? The baby might become depressed at birth, leading to the decrease in the contractility of the heart. So the same thing happens after asphyxia, and if there is any respiratory depression. So in these conditions, this placental transfusion might be a bit slowed down when compared to a vigorous baby. We should wait for at least 60 seconds to allow the blood towards the baby and help in increasing the circulating blood volume. The same thing happens after asphyxia and any conditions of bradycardia soon after birth, either following maternal general anesthesia, or any premature baby having a decreased contractility of the heart. Also, the same thing will happen. So this is another study by Wayne et al., which was published in Lancet 2014. Here they have studied the effect of gravity on the volume of the placental transfusion. This is a multi-centered randomized non-inferiority trial. In that they have tried to prove the non-inferiority of the position of the baby with respect to the DCC. Here 274 newborns were studied. Half of them, 274 newborns, were randomized to the introitus group, where the baby will be kept at the vaginal level, and another 272 babies were kept on the abdomen or chest of the mother, thereby allowing the skin to skin contact. Here, what they have studied was the mean weight of the baby after these two interventions. The interpretation of this study was the position of the baby before cord clamping does not seem to affect the volume of the placental transfusion. That means the position of the baby in relation to the vaginal level of the mother does not affect the placental transfusion. In fact, it improves the obstetric compliance and also increases the mother in fact bonding, because we are allowing the skin to skin contact. And it also has mentioned that holding the baby at the level of the mother might be cumbersome, and it is more beneficial if we allow the skin to skin contact with the mother. So then, seeing the effect of LSCS in babies who are delivered by LSCS, it has been observed that the PRBV, that is the placental residual blood volume, is higher when compared to babies born out of vaginal birth. And they also tend to have a lower level of hematocrit of around 2.91% and around 0.5 grams per deciliter of lesser hemoglobin when compared to the babies who are born by the vaginal births. This is because of the reverse transfusion into the placenta due to the atonic uterus. So here we should emphasize for at least 30 seconds, but 60 seconds of delayed cord clamping is better in improving these hemoglobin levels as compared to the early cord clamping. So next is the cord milking. So the cord milking is roughly around 20 centimeters of the umbilical cord is milked in a pulsatile fashion, but thereby pushing the blood which is present in the cord towards the baby's circulation and allowing for refilling of the cord in between. This is done usually around 3 to 5 times. So what happens in this cord milking is it speeds the process of the placental transfusion, but this is not physiological because it's like a transfusion of a sudden bolus of blood into the baby's circulation, and it is intermittent. It is not like free flowing that is seen in delayed cord clamping. So this can be done in babies who need immediate resuscitation, where intact cord resuscitation is not possible. Here we can see in this slide that the difference between the length of the cord that has been milked, 10 centimeters, 20 centimeters, and 30 centimeters, and the number of times, 3 times or 4 times on the total umbilical cord volume per infant birth weight. So if you can see here, the more the length of the cord, the more amount of the blood volume, umbilical cord blood volume is transferred to the baby. And if it is milked 3 times and 4 times, it is almost similar. So this is the effect of the cord milking on increasing the blood volume of the baby. So what can we do the umbilical cord milking in all babies? So there have been several studies observing the effect of umbilical cord milking in preterm as well as the term infants. So in this systematic review and meta-analysis by Dr. Haribalakrishna et al., so the umbilical cord milking has shown a higher rate of severe IVH when compared to delayed cord clamping in babies less than 32 weeks of gestation. And here by Professor Katheria et al., published in JAMA 2019, the association of umbilical cord milking versus delayed cord clamping was associated with a higher risk of severe IVH among preterm infants. In this study, a wide range of gestation was taken from around 23 weeks to 36 late preterms, 36 plus 6 weeks. So, but there was a increase in the severe IVH in the lower gestational age babies. Here you can see this meta-analysis and different studies you can see here. And here we can see the diamond here pointing favors towards the delayed cord clamping group, and it does not favor the umbilical cord milking group, thereby raising the concern of intraventricular hemorrhage in preterm babies who undergo the umbilical cord milking. This is due to the rapid changes in the blood volume that pushes the bolus of the blood towards the baby, thereby leading to the fluctuations in the mean arterial blood pressure and the fluctuations in the cerebral blood flows, thereby causing causing the germinal matrix hemorrhage. So, how does this intact cord milking works? It works by improving the pulmonary blood flow, and it allows the assist in the early onset of breathing, and it is allowed in babies who need immediate resuscitation, and the cord needs to be cut and handed over to the neonatologist. In this study by Katheria et al., intact cord milking allows the greater placental transfusion than delayed cord clamping in premature newborns who have been delivered by cesarean section. So this study was done because when most of the preterm babies, because of some complications, they tend to be delivered by the lower segment cesarean section. So there the same effect happens, the uterine atony and decrease in the blood transfusion towards the baby, particularly more so in preterm. This umbilical cord milking was studied. So it has shown greater transfusion in only preterm newborns delivered by cesarean section. So how many times do we need to milk the cord? In preterm babies, it is recommended to do around 4 times for 20 centimeters of the cord. And for term babies, we can do the intact cord milking for around 5 times. So that here you can see in this diagram, so that blood goes towards the right atrium and then the right ventricle, thereby increasing the pulmonary circulation and then followed by increase in the systemic circulation as well. So then there was this study in which the subgroup of 28 to 32 weeks was studied again for umbilical cord milking versus delayed cord clamping in around 1019 babies. In this, they have showed no difference in the rates of severe IVH or death in this subgroup. So now the NRP textbook and also the ILCOR guidelines also advocate against the umbilical cord milking in babies who are born less than 28 weeks. It can still be tried with no increased risk of IVH in babies who are born between 28 to 32 weeks who need immediate resuscitation. If the baby does not need immediate resuscitation, then delayed cord clamping can be allowed. And in this trial, pre-mod 2 trial, the umbilical cord milking was associated with an increased risk of severe IVH in the extremely preterm infant born between 23 to 27 weeks of gestation. So that's why this trial and then this Katheria et al. Trial from JAMA 2019 had to be stopped midway due to the concerns of the increased risk of severe IVH in the preterm babies. So they cannot be put in that subgroup of umbilical cord milking, because delayed cord clamping has been shown to be beneficial in that condition. So there is one more entity called cut umbilical cord milking. So this is more often practiced in the low resource countries, where the umbilical cord is clamped and cut away from the umbilicus of the baby, and then a long segment of the umbilical cord is milked by the neonatal resuscitator towards the baby by 2 to 3 times. There has not been a considerable number of studies for this maneuver, and there are no statistically significant results published for the same. But this study is inferior in the sense that it defies the physiology of the baby by allowing the clamping and cutting of the umbilical cord before the onset of the respiratory efforts of the baby. This is against the physiology of the fetal to neonatal transition itself. But in situations where the other modalities have not been possible, this has been shown to slightly improve developmental outcomes. So now comes the new exciting maneuver which was tried in newborns, that is the resuscitation with intact cord. There have been a number of studies for the same, both in Indian studies as well as the studies from the foreign countries. So in this study, this is an Indian study in which the resuscitation with intact cord versus clamped cord in late preterm and preterm term neonates were done. It's a randomized control trial. And it has been observed that the proportion of neonates who undergo resuscitation with intact cord, the proportion of neonates receiving the positive pressure ventilation was lower, and the expanded Apgar score at 5 minutes, 10 minutes, and the oxygen saturation at 1, 5, and 10 minutes were also higher in the intact cord resuscitation group. So the next is the neonatal resuscitation with intact cord. There are a number of ongoing trials like WENT-FIRST trial, NEPCOD, baby DUCC trial, ABC trial, PCI trial. These are all ongoing, and they are studying at varied gestational ages, and the resuscitation if needed, CPAP if needed in the intervention group, and the timing of the clamping of umbilical cord average is around 30 to 60 seconds in the control arm, and in the intervention arm it is more, that is around 2 to 3 minutes in the intervention arm. And the outcomes that are being studied are the incidence of the IVH, SpO2, heart rate, Apgar scores, and the intact survival without any morbidities, and the need for blood transfusions, and the composite outcome of severe IVH, BPD, and death. So these are all now at the research or experimental phase. And we have one more Indian study from Tamil Nadu by Dr. Usha Devi et al. That is the delivery room care and neonatal resuscitation while on intact placental circulation. That is RIPC, resuscitation on intact placental circulation. This was an open label single arm study in babies. They have studied from 24 weeks onwards up till term gestation, but most of the babies were around term gestation, and they have proposed that resuscitation with intact cord is feasible and can be done in the newborns. So for this, we need some special equipment that we will see in this slide. So what are the challenges of intact cord resuscitation? So we should have a proper resuscitation trolley which can be brought close to the mother side, and preferably near the mother's hip. And it should have all the aspects, like it should have all the equipment, the pulse oximeter, and it should provide warm care to the baby, and it should have the enough space for the neonatologist to perform the resuscitation, and there should be access of the baby by the neonatal team, and there should not be interference for the obstetrical team, and we should not breach the sterile fields as well. And the baby should not go into hypothermia, and the length of the cord also plays an important role, and the access to the baby is very important. But these all trials have proved that this is in fact possible to do the resuscitation with intact cord, and this might come up in more centers in India if more and more studies emphasizing the importance of the same comes up. So this is the resuscitation equipment which can be brought close to the mother's hip, and the resuscitation can be continued with the intact cord. So now moving on. The latest is this ABC approach, as we see in the resuscitation of the neonates and older children. For babies who are immediately born also, this ABC approach has been proposed, in which we should first aerate the lungs of the baby. We should allow the baby to breathe, then only followed by the clamping of the umbilical cord. And the other one is the ventilation while still connected to the placenta. VDCC is feasible by seeing all these promising studies and their results. So, but these are still now in experimental stages and in research levels, but them coming into the regular practice may be down a few years of line. So there are 10 recommendations given by the ILCOR while resuscitating a baby. Let's see them one by one. So for term and late preterm newborns who are born more than 34 weeks of gestation and who do not require resuscitation, in this group, delayed cord clamping more than 30 seconds can be beneficial compared to the early cord clamping. Who do not require resuscitation, for all babies, we should allow the delayed cord clamping. Then for term and late preterm newborns who are more than 34 weeks of gestation, who do not require resuscitation, intact cord milking is not shown to be known to be beneficial than delayed cord clamping. If you consider this scenario where DCC can be done, the intact cord milking ICM is not beneficial when compared to DCC. For Non-vigorous term and late preterm babies who are born between 35 to 42 weeks of gestation. If you want the baby to be taken to the resuscitation trolley immediately, then intact cord milking may be reasonable compared to early cord clamping. It is superior to the early cord clamping. For preterm newborns born less than 34 weeks of gestation who do not require resuscitation, DCC can be beneficial in all newborns, irrespective of the gestational age, when compared to the early cord clamping. For preterm newborn infants born between 28 to 34 weeks of gestation and who do not require resuscitation, in whom delayed cord clamping cannot be done, their intact cord milking may be reasonable and is recommended. So the next is this group of newborns who are born less than 28 weeks of gestation. Intact cord milking is not recommended only in this group. So then effective positive pressure ventilation is the first priority in newborn infants who need support after birth. So using a T-piece resuscitator to deliver the positive pressure ventilation is preferred to the use of a self-inflating bag. But because both T-piece resuscitators and flow-inflating bags require a compressed gas source to function, a self-inflating bag should be available as a backup in the event of compressed gas failure when using any of these devices. So always keep an ambu bag as a spare, even if you are having a T-piece resuscitator, because it always needs to be a backup because it does not need a continuous gas supply. And the one more last recommendation is use of a supraglottic airway may be considered as the primary interface to administer positive pressure ventilation instead of a face mask for newborn infants who are delivered at more than 34 weeks of gestation. So now, after having seen all the benefits and physiology and the different research articles around the delayed cord clamping, we now come to the caveats or the concerns which surround the delayed cord clamping in some special risk scenarios. That is, the first one is optimal time to clamp. So the recommendations, they suggest around 30 to 60 seconds. The studies they have done for around 3 minutes also, in majority of the studies, but at least it is reasonable in both babies born by vaginal birth and LSCS births, preterm and term, to allow for at least 60 seconds of the delayed cord clamping. And next is for babies who are non-vigorous at birth. So in them, the cardiac contractility and all may be lesser, but the allowing the delayed cord clamping will help to stabilize the intravascular volume and better systemic blood pressures and better circulating blood volume, and it might help in improving the ventilation perfusion quotient also in the babies and decreased risk of pulmonary hypertension also in babies who are born non-vigorous at birth. For them also, we should try to do the DCC with intact cord resuscitation in wherever possible cases. So the next scenarios are RH isoimmunization. Babies who are born IUGR or SGA, the concern for polycythemia is noted, but this is also not of statistical significance. And the next one is the twin gestation. So if the first baby is very active and crying well, and if there is no concern regarding the heart rate of the second baby, so we should decide for the delayed cord clamping based on the condition of the baby itself. If the baby is active and well and there is no concern for the second baby, then the delayed cord clamping can be allowed for the twin gestation also. There has not been shown to be an increased risk of polycythemia needing partial exchange transfusion in babies who are allowed delayed cord clamping. So it can be advocated in those subgroups also. And neonatal hyperbilirubinemia, we will come to in the next slide. And there was, as I have mentioned, there was no risk of increased overtransfusion by allowing the DCC. So we have discussed the overall intrauterine blood volume of the baby fetal-placental unit is around 110 ml per kg, but that will be dissipated to the tissues, and the baby's blood circulation stabilizes in the first 24 to 48 hours, and there is no risk of overtransfusion with delayed cord clamping, and there is no risk of hypothermia in babies who have undergone the delayed cord clamping. But we should ensure the delivery room temperature and take the optimum temperature control precautions for the baby by allowing the skin to skin contact with the mother and providing an exothermic mattress in certain scenarios. And there was also no evidence of babies needing resuscitation or delayed resuscitation, and no difference in the Apgar scores in babies who have been allowed to have a placental transfusion. Coming to the effect of neonatal hyperbilirubinemia, in this study, babies who are born more than 35 weeks of gestation receiving delayed cord clamping study, an observational study. Around 558 neonates were observed, and the intervention group were allowed for placental transfusion more than 2 minutes versus the control group, in which that cord has been clamped within less than 1 minute. There is no association which was noted in the cord clamping time in neonates and the need for phototherapy. There might be a marginally high bilirubin. Here you can, if you can see in this Bhutanese nomogram, our specific nomogram. So these bars are the bilirubin values of the babies who are allowed the delayed cord clamping. Here you can observe they are almost close to the as close to this 40th and 75th and 95th percentile, and this DCC does not affect uh, the jaundice levels in the babies. There might be a slightly increased risk in need for phototherapy, but definitely no increased risk for either for the double volume exchange transfusion or the RH isoimmunization in babies after DCC. So this is an Indian study from AIMS, in which they have studied the delayed cord clamping in RH allo immunized infants. RH allo immunization, if you observe, has been a major cause of neonatal hyperbilirubinemia, neuromorbidity, and late onset anemia. So here in this study, they have observed the effect of delayed cord clamping on the RH allo immunized infants. So they have taken a group of infants with between 28 to 41 weeks of gestation and randomized them to delayed cord clamping and early cord clamping groups. The primary outcome variable which was studied was the PCV values at 2 hours of birth, and the secondary outcomes which were studied were the incidence of double volume exchange transfusion, partial exchange transfusion, duration of phototherapy, and functional echocardiography parameters like superior vena cava flow, M-mode fractional shortening, left ventricular output, myocardial perfusion index, and inferior vena cava collapsibility index during the hospital stay and need for blood transfusion until 3 months of life. So the neonates were managed as per the protocol. So the mean gestation of babies who were enrolled in this study were around 35 weeks, and the mean weight of the babies were 2,000 to 440 grams respectively. The DCC group babies had a higher packet cell volume at 2 hours of life. However, there was no increased need for DVET or partial exchange or duration of phototherapy or echocardiography parameters, or no increased in the need for the blood transfusion until 3 months of age was noted in this study. So the conclusion of this study being the delayed cord clamping in RH allo immunized infants improved the hematocrit values concentration at 2 hours of age without any other significant adverse effects. There are few genuine contraindications to delayed cord clamping. Those are placental abruption, bleeding placenta previa, bleeding vasa previa, and cord avulsion. In these conditions, the delayed cord clamping should not be done because of the risk for maternal PPH and also the neonatal anemia. In these conditions, the cord should be clamped immediately and the baby should be handed over to the pediatrician or the neonatologist. So, in our unit, we have done a quality improvement study. This was done by our NNF fellowship, Dr. Abhijit Auradkar. And in this, the quality improvement initiative on delayed cord clamping in newborn infants who are born in our hospital was studied. So this was done 2 years ago. This was a 6-month duration QI project, in which all the singleton babies and twin babies who are delivered at more than 30 weeks of pregnancy were included in the study. The exclusions in this study were baby who had fetal distress or resuscitation need for resuscitation at birth, because we don't have the resuscitation trolley which can do the resuscitation with intact cord. And the babies who were born following the RH immunization were also excluded, who had the ICT positive. And monochorionic monoamniotic twins also, the effect of DCC in this subgroup is not yet known. And any twin pregnancy with the second twin showing the fetal distress, this group was also excluded. And any major congenital anomaly such as gastroschisis or omphalocele that may interfere with the intervention was excluded. And any documented twin-to-twin transfusion syndrome was also excluded in this project. So then here the fishbone analysis was done. So in which the different parameters have been noted down. So policy, people, place, and procedure. So policy is there was no existing hospital policy, and there was lack of clarity or skill about the procedure and the risk of uterine bleeding and stem if the parent is opting for stem cell banking. So that also was noted under the procedure. And coming to the people, the lack of awareness among the staff involved, that is the both the delivery and the newborn care. And PPH concern from the side of obstetrician, hypothermia, polycythemia, jaundice, IVH concern for the pediatrician. And there was no reminder before the delivery. So, and the place, OT and delivery room, the temperature maintenance was the main concern. So all these were plotted on the fishbone analysis, and this led to the poor compliance for delayed cord clamping. So in this, the test changes that were studied were the DCC protocol preparation and education of the quality improvement team, which constituted of the one anesthesia doctor, obstetrician, neonatologist, and the nurses from both the obstetric and the neonatal side. And designing of a delivery checklist and WhatsApp reminder for the same, the stressing the importance of delayed cord clamping. And there was a procurement of the clock with seconds hand, and it was stationed at all the delivery areas, and the timekeeper being the pediatrician. And there was also a note on maintenance of the delivery room temperature to prevent the hypothermia in the babies, and the operation theatre temperature was set at around 25 to 28 degrees centigrade. So the outcome was the number of neonates receiving DCC, and the number of neonates with jaundice requiring phototherapy or DVET, and number of neonates who had polycythemia needing partial exchange transfusion. So this was the flow diagram of this QI project. So initially it had the PDSA cycles. In the initial first 2 months, it was the protocol preparation and education of the team, and doing PowerPoint presentations separately for doctors, nurses, and stressing the importance of the DCC. Initially, the DCC rate was around 35 to 40% in our hospital. But then after this QI project, the complaints to the DCC started improving. And then by doing the PDSA cycles, the problems which were arising in between were also solved. And subsequently, by the end of the study, here you can see that the complaints rate became to about 83%, and the euthermia rates also improved here. And so the main things that they have done were they have incorporated a delivery room checklist, and they formed a WhatsApp group with reminders, and they have also kept a clock with seconds hand, and the pediatrician will call aloud the time of the delivery and count the time, like 15 seconds left, 10 seconds left, like that. So thereby increasing the compliance of the overall team. And the delivery room temperature was also taken care of by switching off the ACs 20 minutes prior to the neonates delivery, and targeting a room temperature of 25 to 28 degrees. So we can observe that by doing the QI projects, we can improve the overall practice of any intervention, not only delayed cord clamping, whether it be the skin to skin contact or admission hypothermia or infection control practices. Everything can be improved by doing the QI projects in your own units. So thank you all for your patient listening. Next week, we will come up with again another interesting session. So stay tuned to our KIMS Cuddles channel for more such informative videos. Thank you.